Hi everyone, my name is Dr. Taylor McGann and I am an assistant professor at the University of Indianapolis, and I'm here today to talk with you about outpatient occupational therapy. So before we get started, I always think it's appropriate to have a little bit of background on your speaker who you're going to be listening to. So just some information on me. I was born and raised in South Bend, Indiana. Currently, I live on the south side of town in Greenwood with my husband Casey and our two pets, which I had to include a picture of up there. We've got a border collie and a Bengal cat, and soon to be, with the bottom picture, we'll have a little baby of our own due this August. So we're very excited about this new chapter and being able to join all of you in the ranks of parenthood. I have a master's degree in occupational therapy from Mount Mary University up in Milwaukee, Wisconsin. I did one of my fieldwork rotations down here at an IU hospital and really loved Indianapolis and pursued my first position as an OT down here as well with Hope Ridge Pediatric Specialists. I remained with them until transferring actually into my academic role at the University of Indianapolis. While with Hope Ridge, I did serve as a clinical manager for the Greenwood location as well as a lead OT. I have specializations specifically within feeding, eating, and swallowing, so we can talk a little bit about those later on in the presentation. But during my time as a clinical full-time therapist, I went back and pursued a post-professional doctorate in occupational therapy, and I received that with an emphasis in family-centered practice. So I'm honored to be here to be able to talk with families and share some of this insight and hopefully increase your understanding of how outpatient OTs can better serve you. So I first wanted to start with just a little bit of background information on the difference between outpatient, which on my slides you'll just see as OP, and school-based OT. So I understand that in the state of Indiana, you can receive first steps therapy from birth to 3, and during that beautiful window you have a lot of engagement with your occupational therapist and maybe some of the other providers like the PT and the developmental therapist and the speech pathologist. However, then your child enters this range of 3 and up, and maybe they're just receiving school-based and you haven't searched into what outpatient therapy can do, and you kind of lose contact at this point between the provider and the family. And the reason for this, it's not because school-based therapists don't want to have relationships with parents. It's just that that's not set up that way outside of IEP meetings and consultative appointments for there to be a ton of back and forth. They have extremely large caseloads. I have several friends who are school-based therapists. And really, I think that this slide can serve to just show you that school-based therapy has a central focus on supporting your child in their occupation of being a student. So what they're going to address in a school-based setting is going to look very different and similar in some areas for what we might address in the outpatient setting. So I have a couple of bullets under each setting there for you. It's not an exhaustive list. There are certainly other things your child may be working on in school, but for the most part, your school-based therapist is going to address the sensory processing and regulation piece, so their ability to filter all of the stimulus that's coming in and out of our brains so that they can have appropriate attention to task in the classroom. They may also be working on some visual motor integration and visual perceptual skills. A lot of times these skills are seen in handwriting tasks, in cutting. They'll also be working on, can your child navigate the school environment, especially if your child is transitioning between different classrooms or is of the age where they have a locker. Can they manipulate all of those components in order to get to class on time? Can they carry their lunch tray? through the lunch line, take it to their table. So navigating the environment can look fairly broad. You may also see a school-based OT working on some life skills with your child, but this is going to be more specific to if your child is in a life skills classroom. So if they are not in a life skills classroom, it's unlikely that you would see life skills being addressed. And then your school-based OT, of course, can do consultation with your child's teacher for some maybe behavior management, or maybe they'll just do some consultation with you for carryover into the home. Now they have, again, in school-based therapy, I cannot stress enough how large their caseloads are, very typically speaking, and group therapy and one-on-one therapy are both used in school settings. And your child also, if you go to your IEP meetings, you can kind of follow along with the plan of care that's being written, and it will tell you how often your child is being seen, and if it is group-based or if it is inclusive in the classroom, or maybe they're doing some pull-out into a sensory room or a treatment room, and your school-based therapist can help facilitate any of additional questions that you might have for that. Now, on the opposite side, for outpatient therapy, our central focus here is family goals and supporting your child in achieving age-appropriate skills and occupations. And that can be very broad. So again, similar to school-based, we also can address sensory processing and regulation. We can address visual motor integration and perception, fine motor development, gross motor development, direction following, sequencing, augmentative communication in combination with speech therapy. We can also address ADLs and IADLs. So just to give a few brief examples, ADLs are going to be activities that your child needs to do to take care of their body every day. So this could be bathing and showering routines, toileting and toilet hygiene, dressing, swallowing, eating, feeding, having functional mobility, and actually as well, sexual activity is going to be included in this. And maybe your child isn't of an age where you're thinking of sexual activity or sexual expression, but as you enter those teenage years, this is something an outpatient therapist can absolutely assist you with. Children will advance and mature into sexual beings just like the rest of us, and we have a very unique opportunity as occupational therapists to help navigate this new stage with you. For IADLs, these are instrumental activities of daily living. So this could be the care of pets. Maybe you guys own pets like I do, and you would really love for your child to be able to start helping with some of those things at home. So we could help establish those routines. This could also mean communication management, whether that be verbal, nonverbal, sign language, or the use of an augmentative device. This could be meal preparation and cleanup. This could be safety and emergency maintenance. This could also include sleep, leisure interests, job interests, and volunteer participation. So you can see that the scope of what an occupational therapist can do is very broad. Now, where we work will limit that scope. So again, as a school-based therapist, they're going to be looking at the things that support your child as a student. But at an outpatient therapy clinic, we can look at this broad sense, and really we can focus on what are your priorities for your child in order to help them become more independent. I wanted to go over a couple of commonly asked questions. So these are questions that I have a lot of parents email me about or phone me about. So one of the biggest ones is, how do we first get referred to outpatient therapy? And the first thing that you would need to do is have a discussion with your child's primary care physician. So a pediatrician, a psychologist, a psychiatrist, can all refer to occupational therapy. So right now we are not a direct service provider. We do have to have a referral from a physician in order to engage in therapy. But there are not very many doctors that I've come across where if a parent goes into that meeting and articulates to them why they feel their child would benefit from OT, you're not going to run into many barriers on doctors not wanting to open that door for you, because again, it's a positive thing. It's to increase independence and increase skill level. The second question is, how many times per week would my child need to be seen in outpatient? So this is a big question because when you engage in outpatient therapy, it is a big commitment and it's a change to your normal schedule as a family. And we understand that as therapists. We are asking you to join us in this journey of outpatient therapy, and we're going to be asking you to do things at home with your child outside of therapy, and also commit to seeing us 1 to 2 times a week. And I'm going to use the 1 to 2 times a week range loosely because ultimately the frequency of services are going to be determined after your initial evaluation. So you will see an evaluating therapist. They'll complete between a 60 and 90-minute evaluation with you, and then they'll be able to tell you based on their assessment how many times a week they would be recommending services. But one thing I want you to know as a parent and caregiver is that if the therapist is recommending 2 times a week, but this isn't feasible for your family, it's okay to vocalize that and to request something that's more conducive to your schedule. Another common question is, can I stay at the outpatient session or can I leave? This might be 1 hour that would be really nice to run to the grocery store or to go to Starbucks and have a coffee and read a book. That's all going to be determined between you and your therapist. I would say there's a yes included in both of those can I stay and can I leave questions. There are definitely times from my personal practice where I appreciated when a parent would stay so that I could provide them with some education or maybe show them, hey, your child just achieved this new skill. I would love to show you how they did that so that you can then reinforce it at home as well. So those are just questions that you are more than welcome to just have with your individual provider. What goals will the therapist work on? Well, again, this is going to be determined by your individual evaluation, but I would encourage you to always go in to your evaluation with something that you would like the therapist to work on with your child. And you can simply tell them, I would love for my child to achieve this. It could be writing their name. It could be putting on their clothes independently. It could be having improved social skills with peers. We can have a ton of goals that we're able to work on, and it really helps us make this family-centered and client-centered if we know what's most important to you. What if my child doesn't like his or her therapist? This happens, right? We're all individual people and not every combination clicks. My advice to you would be to give it some time. There is a window of time where you're building this therapeutic relationship between you as the clinician and your client. And sometimes that doesn't click right away, but over time they do build a relationship with one another. Other times there are just poor pairings, and that's okay. And we know as therapists, not every child is going to adore us. And I tell my students that all the time. Just because you're great with kids doesn't mean every child, excuse me, is going to want to work with you. And as a parent, you can vocalize this to the clinic manager, to the therapist themselves. It's nothing personal. We just want your child to make the best progress that they can. And sometimes we aren't always the best pairing, and there could be other therapists your child could be paired with that might have more therapeutic success with them. So never be afraid to advocate for that for your child. How long is an evaluation? So I mentioned this earlier, so about 60 to 90 minutes for an initial evaluation. And then it's important to know in the outpatient setting, when we complete an evaluation, typically it will take after that point 4 to 6 weeks, depending on your insurance carrier, to get approval for you to then be added to the treatment schedule. And that's going to vary, like I said, depending on your insurance carrier and the facility that you're seeking services at. But there typically is a couple week span after the initial evaluation in order to have our documentation approved by the physician and approved by insurance. Is the evaluator my child's treating therapist? Not always. So sometimes the evaluating therapist will then become the child's treating therapist, but sometimes there might just be a team of individuals who just serve as evaluators, and then other people in the clinic are more treatment-based. So that's a question to ask at your visit, and you can ask that to the receptionist or, again, to the person completing the evaluation. Who can treat my child in occupational therapy at an outpatient center? So within occupational therapy, your child could be seen by the registered occupational therapist or the registered occupational therapy assistant. So both are board certified, but there are different educational tracks that allow for an OTR to be that supervising level therapist, and then the assistant would only be doing treatment. So they're going to carry out all of the treatment plans that occupational therapists put together from an evaluation. Can OT help my older, and I put in brackets here, teenage child? Absolutely. So outpatient therapy is not just for the littles, it's for birth to 18, and then some treatment centers can go beyond that 18 range as well. My personal practice, where I was employed, we were birth to 18 specifically, and I absolutely loved my teenagers and my older kiddos on my caseload. When we reach that teenage age, we might be looking at more in-depth life skills like job seeking, what it would take to have an interview or to complete tasks on a job, being able to have appropriate social responsiveness and behavioral control, meal preparation, anger management, coping skills. There's a ton that we can do for the teenage and the older child as well. All right, so when should you consult with an outpatient or an outside OT? The good news is it's whenever you want. You can talk to your pediatrician about things that you would like to see your child doing more independently, but my personal recommendation would be early intervention is key, and it's okay if you've missed that early intervention window. There's never a time where it's too late to engage in services. So sometimes it's not always feasible for parents or for families to be in first steps and outpatient and then transition to school. We're asking a lot of you guys, and we understand that. So there's never a wrong time, but sooner the better in my personal opinion. When consulting with outpatient OT, just understanding again that it's a partnership between you and the therapist, so it is a group effort. Goals will not be met in the 1 to 2 hours a week that we as the specialist are seeing your child. The reason for that is you're the primary caregiver, you're spending a lot of time with the child, and we want to be able to send you home with some home programming in order to achieve those skills across multiple contexts. As an outpatient therapist, it was a great success when a child would meet a skill in my clinic. However, if they couldn't then generalize the skill to home or to school or to the community, I didn't really see the validity in what I was doing. So I want to make sure that when children meet skills in outpatient, that they're taking those skills to any setting that they find themselves in. All right, so let's talk about some developmental milestones. I just want to touch on this. I believe in ordering developmental milestones by sequences versus by age. And my rationale for this is that I think oftentimes as parents and caregivers, we can get really stuck with a number. My child should have been doing this by X age. And really, we all develop at different rates, and it's okay that some kids are developing quicker than others or slower than others. So let's just look at these developmental milestones based on sequence of when they should be achieved, what comes first, what's followed. And some of these might be a little bit of a review. So for gross motor, we're going to see our infants first rolling over before they're able to sit up independently. They will then engage in crawling and pulling themselves up to stand before they can stand alone, and then again before they're able to walk alone. For language, we're going to see a lot of early language indicators will be eye contact and imitating facial expressions, and I have that under social as well because it is a social skill, but it's also a building block to language development. So after that, we'll see children, point to the item that they want, or maybe bring the sippy cup to the parent and it's empty. That's a great communication without any verbal exchange that, hey, here's my sippy cup and I want more. You'll then go to first word utterances, progressing to two-word phrases, and then the use of simple sentences and so on and so forth from there. For social, starting with that basic eye contact, responsive smiles, engaging in parallel play. So parallel play is going to look like, can I sit down and play with the car while the child sits down and also plays with the car? So we're engaging in the same activity next to each other. And then from here, we might build into imaginative play. So can we crash the cars into each other? Can we drive them up our arms and have them slide down the other side? From here, we'll see children engage in sharing. This can be hard, and turn taking as well for some higher level social skills. For self-help skills, we would see earlier on in the first year of life, children bringing hands to their bottle to help support and hold the bottle. We may see them engaging in finger feeding. They'll advance to drinking from a cup with no assistance. They'll attempt to use a spoon, and it's okay if they're unsuccessful, but just their willingness to try, we really want to support. They'll then advance in a couple of years to having some bowel and bladder control, and then dressing with no assistance. If you are a numbers person, and if you were kind of hoping with this webinar that I would have said, okay, by age 3, this is what your child needs to accomplish. By age 4, this is what they need to accomplish. If you're a numbers person, it's okay. You can ask your evaluating therapist at the outpatient center to tell you what developmental level your child is falling into. I don't believe in assigning one age to every child for reasons I've already stated. However, when you do come to an evaluation, we'll do several different assessments and we'll categorize your child into age equivalents. And this is important in the outpatient setting because we have to show insurance why services are needed. And we would absolutely share those results with you to give you a better picture of age-wise where your child's functioning at. But again, do not get too consumed with the number. Let's look at the sequence. So some red flags for me as an occupational therapist that I wanted to go over with you guys this morning is a child is unable to cross midline. So this means that they're only using one hand to do different tasks versus using both in a coordinated manner. Some examples of this is maybe they're just holding toys with one hand, and during cleanup they're only tossing toys into a bin with one hand. They're maybe neglecting one side of their body. This picture that I have up here of this cross, these intersecting lines, This is a really good pre-writing skill that I will give to children in an evaluation to see if they can cross midline. If we're asking a child to draw letters, but they're unable to draw that cross, then we have a red flag there. Using scissors to snip is another crossing midline activity. The child has to use the scissors in one hand, use the other non-dominant hand to stabilize the paper. Writing activities also take that dominant hand in what we call a helper hand, which I have pictured here on the bottom. So you can see the child's using the pencil in his right hand, and with his left hand he's stabilizing the paper. And then on the bottom other side of your screen on the corner is a picture of a child using fasteners for clothing. So this kiddo is trying to zip his jacket, which again takes coming to the midline of the body and using both hands in a coordinated manner. The child has not yet established hand dominance, but we're asking them to write letters. So for me, this is a big red flag that we need to back up the skill and further develop the hand strength for confidence in writing tasks. So yes, children can be ambidextrous and use their right and left hand equally, but that's a very small number of children. So if your child is fatiguing while they're writing and they're going from right hand to left hand and vice versa, this would also be a red flag that we have some strengthening of their fine motor skills that needs to be done. The second bullet here is we're asking a child to match letters or numbers, but they're inconsistent with matching colors or pictures. And when I say pictures, I mean 2 dogs on a picture, 2 cats, the red ball, a sun, a moon, so these basic pictures. An inability to match colors or pictures may be a signal that we need a visual exam, and occupational therapists are able to administer different visual assessments as well, and some OTs are specialized as vision therapists. We want a child to complete teeth brushing independently, but hand washing hasn't been mastered yet. So this is a big one that I see, and it's okay. So we want our children to do all of these things, and it's the occupational therapist's job to be able to tell you from a sequence standpoint what comes first. And there are a lot of different things that interfere with teeth brushing beyond just mastering a routine. With teeth brushing, we could have some oral motor sensitivity, some sensory processing deficits. Maybe the child doesn't know how to spit, so we're swallowing and consuming the toothpaste. And OT can help with all of those components. We encourage our child to, and this is an example I have here, get the book and bring it to mom. However, the child doesn't consistently follow the direction of sit down. So looking at maybe we're requesting our children to do higher level direction following, maybe multiple steps, before they're able to follow consistent basic direction following. The last point on this slide is maybe the child is having frequent meltdowns. For me as an occupational therapist, I always see that behaviors in the form of meltdowns first serve as a form of communication, and then I understand the child's trying to communicate something, and now I'm going to look at it from a sensory processing perspective. Is there something in the environment? Is there any sort of stimulus that's causing this behavior to occur? Another reason for frequent meltdowns could be a breakdown in communication. I know that as an adult, we can all agree that it's hard to have a conversation with someone when they don't understand what we're saying. So again, this is no different in children if they're unable to effectively communicate their needs. And this may be with you as the parent, or maybe you don't see this at home and this is more of an issue in school. Parents and caregivers are really good at reading what the child needs, but then when they go into other settings, maybe their peers don't understand what they need, or their teacher or their aide, and this could be another cause for frequent meltdowns. Rough play with friends might be occurring more frequently than appropriate peer play, and this can come in many different forms. So just not sharing, not turn taking, using rough hands, and not respecting personal boundaries. So this is a big area of an activity of daily living for children. Their biggest occupation is play, and we want to support them in their ability to have appropriate play, because play is extremely motivating to then acquire skills in other areas. Not able to keep food or drink inside of the mouth. So this might be a sign of an oral motor deficit. So if your child is drinking from a cup and they're losing 50% of it down their mouth, or maybe they're an eater who after they're done, their face is full of their food, but they have no awareness of it. This could be some decreased oral motor awareness, and we as occupational therapists can absolutely help address that with them so that they're more successful during mealtime. So my main point with these red flags that we've quickly reviewed with each other is that we have to evaluate what we're expecting our child to do, and that this is something achievable for them. So there's nothing more frustrating for a child than being asked to do a skill that's at a higher level than they're ready for. And we will see a lot of breakdown, especially behaviorally, if we're asking them to do something that they don't have the prerequisite skill to achieve. So an occupational therapist, a key term we use a lot is the just right challenge. And we are going to be a perfect provider for your child to find that just right challenge while still motivating them and pushing them to reach the next step. I want to spend a few minutes talking to you about activity analysis. So occupational therapists are extremely skilled in breaking down activities and analyzing them. So I have two examples here, one for a younger child and one for a teenage or adult child. So the first one is the activity is using scissors to cut a line on a piece of paper. So this is something children are going to do in many classroom settings. Maybe they're building something on their paper, or maybe they're part of an evaluation at an outpatient clinic, and this is one of the things we're asking them to do. So oftentimes when it comes to scissor skills, I have parents tell me, well, I never thought to give my child scissors because it's a safety concern. So please remember that when your child is being evaluated, the standardized assessments are going to maybe ask them to do things that they have not been exposed to. And that's something that we as the outpatient therapist especially, we need to know that because it greatly influences not necessarily the end score that they will get, but our interpretation of that score. So anyway, aside from that, the skills needed just to use scissors to cut a line on a piece of paper is first going to be postural control, to sit upright in a chair, at a table, or a desk. The fine motor grip and strength to hold the scissors in the dominant hand. The fine motor dexterity to place the fingers into the scissors correctly and then understand from a motor planning standpoint how to open and close the scissors. Bilateral integration, so again using our hands together to do a coordinated activity. And as I mentioned earlier in the presentation, with scissor skills, right, we're going to cut with the dominant hand and use the non-dominant hand to support the paper. Bilateral coordination, again, using both sides to do one activity. If there's a breakdown in bilateral coordination, what I'll often see is the hand that's trying to do the cutting, then the helper hand all of a sudden is imitating that. So it takes a very high level skill to have a dominant hand do an active motion while the non-dominant hand remains stationary. Visual motor and visual perceptual skills to see where the line is on the paper, how to orient the scissors to the line, and then to notice where their hands are in relation to these sharp scissors. It's very important. And then with all of that, they also need sensory regulation to avoid unwanted stimulus and maintain attention. So if they're working in a classroom and a peer suddenly starts talking about basketball, or they take out a toy, or a siren goes off and an ambulance drives by the school, the child's going to be able to have to organize that auditory stimulus in order to maintain attention to the task. For a higher level skill, so maybe you want your child to be able to go to the movies with their friends. And this is something that an occupational therapist can absolutely use activity analysis with to help break those skills down. So there are a lot of skills that I've listed here, and I'll quickly run through these with you. So first, the child is going to need to have social communication, both from a receptive and an expressive standpoint to request a ticket. They're also going to need to have some money management skills to take out an appropriate amount of money to pay for the ticket. They'll then be bombarded with some auditory information, and they'll have to use auditory processing to follow directions to locate the theater. Is it to the right? Is it to the left? Was there a number associated to it? If they want snacks, they're going to have to use that basic turn taking in line while they wait their turn. They're going to have to visually scan to select what they want for a snack. They're going to have to use appropriate modulation in order to have socially appropriate responses to maybe some emotions that they're experiencing. And these can be positive or negative. So maybe they're just really, really excited to see this movie. It's their favorite candy. This is a great day. Or maybe it's not. Maybe they're excited to see the movie, but they're out of the candy that they wanted. Now, how do I regulate that emotion so that I can still achieve the goal of going to the movies with my friends? When they get to the cash register, they're going to have to, again, use receptive and expressive communication skills and money management when they pay for their snacks. They're then going to have to use fine motor and gross motor coordination to carry the items to the theater. They're going to have to use environment navigation. So can I climb the stairs to my seat, especially if it's dimly lit? Do I know where the bathrooms are? Should I need those? Do I have safety awareness to understand where the exits are or who to walk with? And then again, with sensory regulation, and you hear me talking about this area a lot because all of us are constantly bombarded with sensory stimulus. So again, activity analysis is a skill. We do not expect you as parents and caregivers to come up with all of these lists. Allow us to do this with you and to provide this to you as we engage in the therapeutic relationship. I want to highlight some specialties within pediatric OT. As I mentioned, there are vision specialists. There are also feeding and eating specialists like myself. You can be a certified hand therapist. You can have advanced certifications in sensory integration. You can have advanced certifications or board specialties in mental health. And you can also become an assistive technology professional. So again, this is not an exhaustive list, but you can definitely call different outpatient clinics if you are looking for a certain specialty and ask if anyone on staff has advanced training in this, but we can also at the entry level address many of your needs for your child. I have the one question here, does every OT have the same degree or credentials? So this tends to be kind of confusing right now because there's a dual entry point to the profession. So right now you have to have either a master's in occupational therapy or an entry-level doctorate. Both will take the same board exam, which is regulated by the National Board for Certification in Occupational Therapy. And then every student who is able to sit for that board exam will have come from an accredited university, which is something good that you can be confident in, that regardless of the credential, your child will be receiving excellent skilled service. Now with that, our profession was not always an entry at the master's level, so there are many fabulous practicing occupational therapists who entered the profession at the bachelor's level. So we have very varying levels of degree, but that does not always indicate varying levels of skill. So I just want you guys to know you can be confident if you are scheduled with an OT that they will be getting a wonderful skilled service delivered to them. Thank you guys for your time. It has been wonderful to just share some of my passion and my expertise in this area. I just want to leave you with some encouragement. So we might be the specialists because of the degree that we have. However, you as the parent and caregiver are the only expert in the room, and your voice matters, and your voice deserves to be heard. So please advocate for your child. Please speak up in your IEP meetings about what your child is needing, at your consultation meetings, at your evaluations with us outpatient OTs, or just pull us aside after a treatment session and tell us what you're needing. I believe that parents and caregivers need to be empowered in their role of parenting, and you're doing a great job. Please just let us know how we can better support you, because that's what we're here to do. So if you have additional questions, I have listed my email here for you. I'd be happy to engage in a conversation and help you any way that I can. But I hope you have a great day, and thanks for spending part of it with me.